Okay, good afternoon and welcome to this afternoon's NDARC webinar. My name is Dr. Sarah Feinbach and I'm a researcher here at NDARC. I'm also your chair for this afternoon session. Today is Close the Gap Day, and with this in mind, we would like to show our respect and acknowledge the traditional custodians of the land and show our respect to elders past, present and emerging. I'm joining you today from beautiful Ngambri and Ngunnawal country, and we particularly welcome any Aboriginal and Torres Strait Islander people who are joining us today. Okay, today we're going to be hearing about use of data linkage to determine long-term health and substance use outcomes for clients in residential substance use treatment. It's my great pleasure to introduce you to Dr. Calvert Tisdale, who is one of our research fellows here at NDARC. Calvert's going to be presenting us his PhD work that he's completed over the last few years, and we welcome Calvert in a moment. After Calvert's talk, we will be joined on a panel discussion by Dr. Dominique de Andrade, who's an ARC DECRA Fellow at the Griffith Criminology Institute at Griffith University. She also has many hats. She's a member of the Centre for Mental Health at Griffith University and holds honorary fellow positions at both the University of Queensland and Deakin University. Dom has a ton of experience working with data linkage, and so she'll be able to provide us with some interesting insights and discussion after Calvert's talk. Okay, I'm going to, finally to Q&A. After Calvert's finished presenting, you'll have an opportunity to ask questions. And so please put any questions or thoughts that you have into the Q&A function at the bottom of the screen. We'll try and get through as many as we can. All right, I'm now going to welcome Calvert and ask him to turn his camera on. I'll get out of your way and hand over to Calvert. Hi, Calvert, how are you going?
Hey, Sarah, thanks for the introduction.
No worries, over to you.
Perfect. So thanks everyone for coming today to my webinar. As Sarah said, my name is Calvert Tisdale and I'm a postdoctoral research fellow at NDARC. And today I'll be presenting my PhD work that was completed at the University of Queensland recently with my supervisors, Associate Professor Janni Leung, Dr. Dominique de Andrade, and Professor Leanne Hides. Before I start, I would like to echo Sarah's sentiment and acknowledgement of country and acknowledge the Bidjigal and Gadigal people from where I'm joining the meeting today, and also extend this to the Turrbal and Yagara people that are the custodians of the land at which the University of Queensland is situated, where most of this work was completed. I'd also like to acknowledge the service provider and their staff for providing funding and support for the project, as well as participants who, while de-identified data was used, were still in the project for the purposes of improving the services they attend. And I'd also like to thank the Statistical Analysis and Linkage Unit of the Statistical Services Branch for linking the data. And finally, researchers who directly contributed to the project, Dr. Vivian and Gabriel Campbell, among a lot of other supports. Just giving a brief overview of today, I'm going to start with some background before moving into the data linkage and an overview of the PhD, go through each of my 4 studies before finishing up with the implications of this work. As you can probably see, I'm quite ambitious to fit all of this in, so I might have to skip over the finer details, but please feel free to get into contact or refer to any of the published work if you have further questions. And I'd also just like to use this as a quick opportunity to mention that I will be talking about themes of suicide and death today, so please do with that information as you will. But getting straight into the background, so a common response for moderate to severe and complex substance use disorders is treatment within an inpatient residential facility. This is also colloquially sometimes known as rehab. Typically, these services are 24-hour-a-day care within sometimes, but the majority of drug-free residential setting. And they aim to integrate evidence-based treatments. And this can range from including activities such as individual counselling, group counselling, peer-led activities, pharmacotherapy services. It really just depends on the model. And while there are various models, we won't be going into that today, but just the consistent goals of treatment. And that is to remove individuals from risk factors of substance use, manage the substance use, reduced symptoms related to it, and also improvements in holistic health and functionality. But what does the current research say about residential treatment? Is it effective? From what we know, it has seen improvements in a number of substance use outcomes following treatment, including higher rates of abstinence, reductions in overdose, and even when compared to other treatment options, we see that there's higher rates of abstinence long-term in Australia. But we also know outside of this protective period, that is treatment, the period directly following after discharge has been associated with poorer outcomes. And this is especially true for individuals who leave treatment early or don't complete a treatment program. And this is associated with premature death, readmission, return to using substances, injecting behavior, and hospitalizations as well. Furthermore, despite being a common response, we also see that it is really difficult to research these outcomes. And this is due to the hard to reach and vulnerable nature of this population who access these services. Obtaining reliable outcome data, especially in the long term, is very hard as participants, especially following disengagement and discharge from treatment, have changing contact details. This population experiences increased health concerns and is also very mobile, moving interstate or into country as well. And as such, current research often contains little to no follow-up data, and those that do often have higher attrition among clients with poorer in-treatment outcomes, which may lead to evaluations that are biased. So if we just look back at the previous studies that I presented, we can have a look at their follow-up rates. And while the times vary in terms of follow-up, so from 3 months to 12 months, we can see it sits around 60 to 70%. And while there's a very, very impressive follow-up rate for this population, it's important to note that the people who are missing may not be missing at random, and it may be due to certain factors that represent poorer outcomes, for example. So this is where we can utilize data linkage to hopefully bridge this gap. So administrative data linkage is a method of linking client information with administrative healthcare records or other administrative records. And the key about this, receiving this data, is that there's no identifying information ever given to the researcher. So this is known as the separation principle, where sensitive data stored at the health service is always separate from anything identifying, such that no one ever has both pieces of information. And so using existing healthcare infrastructure, this can be leveraged to create longitudinal data sets that begin to approach the question of what happens after treatment, or what are the long-term outcomes. And this provides us information that might otherwise be unknown or uncollectible. So just to give a really brief example of what this might look like and what it did look like in the current project, what we can see here is a hypothetical participant and their timeline. So the baseline would be when they enter a treatment service, routinely collected measures such as primary drug for treatment would be collected. But beyond that, if they disengage from a service and no longer are contactable, no longer re-engage with the service for further treatment, we won't know what happened to that person following treatment. So we don't know if the treatment was in a way successful, or what it aimed to do was achieved. So what we can do instead is look at what kind of health services they might access after treatment. So maybe they went to an emergency department and then a hospital, and then they went to an AOD service that's exterior to this organization. So there wouldn't be any record of it. We can start to see a bit of their health journey. And what we then can look at is all of these services also collect routinely collected measures at admission. And when we put them all together, we might be able to create a picture of this person's health journey. But what kind of information can we get? So just to take a closer look at one of the services, the emergency department, they use an information system for capturing all of their patient data at admission and also at discharge. And here are some variables that can be collected and It's not extensive, but just to give you an idea of what kind of information we collect. So there's informational, temporal, and geographical information. So just from this episode, we can see that an individual's re-engaged with methamphetamines and has presented to a service for overdose. And they've also been using alcohol. We can see how long the episode was for, and we can also see where it was and how they left the service, for example, self-discharging. So with all of this information, we can plug it into this hypothetical timeline. And now we can start to get a bit of an idea of what happened to someone after they left treatment. So where we previously might not have known, now we can at least get a vague picture of maybe if they returned to substance use or what happened to them in terms of their outcomes. So with this in mind, the aims of my PhD were to firstly characterize a cohort of individuals who access residential treatment. And we also wanted to examine the completion of this treatment within the cohort. And then following this, with this same cohort, we wanted to see what happened to them after they left treatment. So we aim to look at the long-term health and substance use outcomes of this cohort through the data linkage I just described. And specifically, we wanted to know more about the mortality, alcohol and other drug-related events, and suicide-related events. This is just a very, very broad overview of my PhD and also the research trajectory. Data linkage was completed as needed in relation to what kind of services were needed for each outcome. But no need to read it all. We're just going to start at study 1, which is the cohort characterization. So on the right is a visualization of what the linked data look like and what services were being linked to the base cohort. We'll go into it in a bit more detail a bit later on, but for now, we're just going to focus on the base cohort of the residential centres. So no linked data was used in my first study. So for this first study, we wanted to characterize the cohort, and we really wanted to understand the characteristics of people who are accessing these services, at least within the time period. And we also wanted to know more about treatment completion and what it looked like to use it as almost an in-treatment outcome. The reason we wanted to do this is to understand it in a better way so that we could apply it to future studies and potentially use this in-treatment outcome as a predictor for outcomes following treatment. So specifically, we aimed to characterize the cohort and then investigate what predicted treatment completion. So at the time of data collection, very briefly, treatment completion was very different to how it would be now. But it was 4-week cycles which could be repeated with no limit, and completion was considered making progress or having a planned transition out of treatment, and that was indicated by a clinician. And this could either be to a transitional service, such as continuing care or a halfway house, or to community, so no further treatment. A non-completion was anything that was unplanned against advice, and the reasons for early discharge were recorded, and things like behavioural infringements or using substances would result in that. But now looking at what the cohort looked like, a lot of this is what you would expect. So it was a primarily male sample that was mean age of 32. We had a high involvement with the justice system relatively, and this is due to court ordered mandates for treatment sometimes happening as well. The government pension status or welfare status is very, very high because it's a government subsidized treatment service where admission and recurring payments could be very highly subsidized by these benefits. And as you can see, it's very, very high. Treatment completion at the time was very low, on the other hand. So this might be due to the lack of structure in how this was defined. Following year after this data was collected, they actually introduced a much more strict structure in how this was recorded. But unfortunately, we don't have that data. Indigenous Australian status. So individuals identifying as Indigenous Australian was very high. There's a high representation within this cohort. And the reason for that is that there was one of the sites was Indigenous Australian exclusive, such that people who identified or were Indigenous Australian were able to go there. And so you can see in the bottom right corner, the 3 different sites were categorized by adult 25 and over, younger adults 18 to 25, and then Indigenous Australian exclusive. We also collected substance use and mental health measures, although these measures aren't incredibly specific in terms of what they go into. We do have primary drug of concern, and as you can see, this is a primarily alcohol and methamphetamine cohort, and with some cannabis use and an other category. Just quickly, 32 people of that other category were the next highest drug that was used, and all others were less than 5, and hence we had to, for sensitivity of data, combine these. They also recorded abstinence self-efficacy, that is the confidence of refusing drugs in high-risk situations. Low abstinence would reflect the a low confidence to refuse drugs in those situations. We also collected DAS21 information. As you can see, there was 20% missingness at admission, which is already relatively high, and even further at discharge. And so we had to exclude these discharge scores, unfortunately. And you can see that it is relatively high, but not as high as you might expect in a cohort attending residential treatment. And so we use those factors, skipping ahead a bit, to predict treatment completion. And so what did we find? Our main finding and only finding above all other predictors was that stress was predictive of treatment completion. And you can see that in comparison to what the DAS would call normal stress, this is reflective of more severe stress causes a less likelihood of completing treatment. Stress is definitely an under-focused aspect of mental health in these environments, but we don't know much else about stress. We didn't measure what kind of stress people were under, but as you can imagine, transitioning into treatment would be a stressful period in anyone's life. I won't discuss this much further in detail. You can read this paper that is very on the nose in the title, so it shouldn't be too hard to find. But moving on, now that we had characterized our cohort, we wanted to use the data that we obtained from the health services to investigate the long-term outcomes of treatment. And to do this, we wanted to look at mortality. So we know that premature mortality is consistently high among individuals with substance use disorders, and this is further elevated for those who seek treatment for substance use opioids, sedatives, or hypnotics, and also during that period that is directly following separation or discharge from treatment. We also wanted to identify these deaths, as it's important to censor or remove these people when they die, so that we're not following up someone who isn't able to have any more events, which might mislead the data. So there's also an instrumental reason for this. So what we aim to do, among other things, is identify, examine, and quantify deaths in a 2-year period from residential treatment. And today I'm just going to present on the causes of death and standardized mortality ratios that we looked at. So in order to do this, we linked data from the registry of deaths, and as you can see here, I've highlighted it in yellow, and no other services were required for this. So from the registry of deaths, we got the date of death to know if someone had experienced that. And then we use ICD-10 codes to examine the cause of death or additional causes of death as well. So what do we find? We found 36 deaths occurred in this population, which is quite high. And 2/3 of these deaths were due to suicide or overdose. And the overdoses we considered not as suicides just because most of them were inconclusive. So we put them there unless they were ruled as suicides. So 16 people died within the first year, which is also a lot in comparison to the general population. So when we're looking at the mortality ratios, we're comparing the expected number of deaths to the actual deaths with the general population of Queensland, where this research was conducted. And then we also adjusted for age and sex. And we found that there was an incredible risk for this cohort in relation to premature mortality. And I think it's definitely worth highlighting that females in this cohort experience some of the greatest risks for premature mortality. And this is definitely an area that needs more attention, given how elevated this risk is during this period. Unfortunately, I won't have time to discuss this in further depth, but once again, the paper is published, or you can reach out to me if you have any more questions. But now that we'd identified the deaths in the cohort from this work, we were able to censor them in any future work. And as such, we moved on to investigating kind of the main reason we were conducting this data linkage. And it's the initial issue of the difficulty of obtaining outcome data for residential treatment. I mentioned there's a lack of research investigating these outcomes, and as such, they're hard to reach and conduct. So what we do know is this population utilizes health services at a high rate. A meta-analysis estimated this to be 7 times higher for hospitals, emergency departments, and primary care visits, among other services, with global prevalences of acute care utilization being 36% and 41% for ED in hospitals. And we also know that individuals who don't have their substance use needs met by treatment also require greater hospital and ED utilization than those who do receive the treatment they need. On top of this, we also know that this population utilizes mental health services, and this is especially true for certain subgroups. So given this, we can leverage this health service utilization to investigate the outcomes of residential treatment. And so that's what we aim to do. We linked administrative data in order to investigate how much people utilize these services for alcohol and other drug-related events. We then wanted to identify a critical period or period of increased risk for these events occurring. And then finally, we wanted to use the characteristics that were collected at baseline to see if we could predict AOD-related events occurring, or what would increase or decrease the likelihood of it. So alcohol or other drug-related events was created from linkage to all the data sets, and I'll go to the next slide, which will show you these. But firstly, we used ICD-10 codes at presentations to these services, except for presentations to AOD services, where we used any episode as an indication that an individual might be seeking support for substance use, and therefore loosely defined it as a potential re-engagement with substance use. As you can see, this includes all linked data sets, so hospitals, mental health services, AOD services, emergency departments, and also the registry of deaths. Because if a death was drug-related, we would code that as an event before censoring. So now that we've linked all the data sets, how exactly did we extract this information? I just did up a very, very brief example of what it might look like. So once again, that is the 2 years of follow-up data that we might have for someone. And without going into too much detail, what we want to do is identify the number of days from discharge to their first alcohol or other drug-related event. And then we want to see if any of the factors collected at baseline can predict the occurrence of this event. As you can see, they had a hospital episode with a viral infection, but it wasn't alcohol or drug-related, so it's not included. So from doing this type of analysis, we found that there was quite a high proportion of individuals who accessed the service for an alcohol or other drug-related event within the 2 years. And this is especially pertinent because this is typically people would present to these services when they have a more severe issue. Obviously, we can't judge that without looking into it further, but this is quite a good estimation of if someone's returning to a health service or presenting to a health service for a substance-related event. It's probably an underestimation of return to substance use in general. We can also see that in the first month is when the highest proportion of these events occurred, so the first 30 days following treatment, and this could potentially represent an increased risk period for those attending residential treatment following discharge. very quickly looking at predictors, I wanted to highlight treatment completion, which we looked at in study 1, and just show that this was one of our strongest predictors of reducing the likelihood of an individual presenting to a health service for a drug or alcohol event. And we had other predictors as well. I think if you do want to know more about that, you'll have to go to the paper, unfortunately, just for the sake of time. I only scratched the surface, so if you are interested, please refer, or once again, you can ask a question at the end. But for now, we're going to move on to my final study, and that was looking at suicide, suicide-related outcomes. So we know that individuals who seek treatment for substance use disorders are especially high prevalences of suicide, and this includes ideation, ideation, suicide attempts, self-harm, and also elevated risks of premature mortality that is suicide related. And we touched on that earlier as well. We also know that this risk is especially high during that period following treatment, and it's similar to premature mortality. So in study 2, when we looked at mortality, we did see this, and we saw also that there was a really high proportion from the deaths that occurred in our cohort that were due to overdose or suicide-related causes, and that was over 2/3 of deaths. And so we wanted to expand on this and look deeper into suicide, and specifically wanted to quantify and examine suicide-related events that occurred amongst health service presentations, and also look at the predictors for these events as well, based on the characteristics collected at baseline. We also looked at recurrent events of suicidal behavior, but I don't think I'll be touching on that today, unfortunately. So in this final study, we used all of the databases except for the AOD services. And using these databases, we looked at the ICD-10 codes that indicated suicide-related events. As a limitation, we did have to combine ideation, self-harm, and attempts, and suicidal death, which are all very unique aspects of suicide. They have their own risk factors and interactions, even with each other. So I do understand that this is a limitation, but unfortunately with the sample size, we did have to do this, but it still gives us a general idea of suicidality within the cohort. And so there's just a visual representation. We linked all except the AOD services. So through this linkage, what we found was that there was 175 individuals within 2 years of discharge across 298 episodes of suicide-related behaviors in the 2 years. So breaking these 175 individuals down to the frequency of events, we found that 119 people had 1 event, 24 people had 2 events, and there were 32 individuals who had 3 or more suicide-related events within the 2 years. Looking deeper into these events, we can see that they're primarily due to attempts or harms, suicidal behaviors, with the majority of 72% being coded as such, lesser so for ideation, and there were 19 suicide-related deaths within the 2 years as well. So the highest proportion of events did occur within the 30 days from treatment. Probably also could represent this period of increased risk that we found in the 3rd study related to alcohol or drug-related events. As you might expect, we did see that emergency departments were the most utilized service for this. There was 23 cases where they presented to emergency departments and were moved to hospital on the same day, but we counted these as emergency departments as this was their first contact. So once again, jumping into what factors that were collected at admission to treatment are predictive of these events, just focusing on treatment completion, we can see that once again, it's very protective of these events occurring and reduces the likelihood by half in comparison to those who didn't complete treatment. So this is something that we really would like to focus on. That paper isn't published yet, but it is currently under review. So get into contact if you want more information. I just thought I'd present this summary of outcome findings and predictors just to show you that there's a lot of things that I didn't talk about. But also on top of that, just to remind you that it's important to remember the caveat that these individuals attending these services are often people who've had very complex health journeys and histories. And the outcomes that we see in this study in the 2 years are not isolated to the engagement with treatment. From that, I'm going to move into the implications of that summary of outcome findings. I won't go into depth on all of these points, but I just wanted to outline some of the more important implications that I thought of. So obviously there's a period of increased risk following treatment. So enhancing support during that period through transitional and continuing or aftercare to target those periods and mitigate the risks that occur during them. Also, all of the deaths in this study were preventable. So implementing prevention around suicide within treatment, and also managing the co-occurrence of suicidality and substance use, which is very common. There's been studies that have shown that there's definitely a benefit. In Australia, these studies were completed to show that those who attended these substance use treatments with suicidal events actually responded very well to integration into residential treatment. As I touched on very briefly before, treatment completion was one of our strongest predictors of improved outcomes following treatment, or improved outcomes in the sense that it was protective against these events occurring. On the other hand, we saw that people with a higher number of previous episodes to treatment had poorer outcomes. And so they're almost the same, different sides of the same coin, in the sense that we want to increase treatment completion while reducing the readmission. And so this can be achieved, and there's research that attempts to achieve this through improving motivation and treatment engagement. And I think there's room for treatment services to implement such strategies. I also just wanted to mention that time in treatment, we didn't include it as it was highly collinear with treatment completion. And so we excluded it as it didn't add any variance beyond treatment completion. And this might allude to the fact that treatment completion is just a reflection of more time in treatment. And that's not necessarily a limitation, as we know that people who spend more time in treatment receive more support and potentially more engaged with treatment at the end of their episode, meaning that they might have more support available when they do discharge. And I think this is indicative of what we found. Finally, I think these engagement opportunities, we need to leverage these re-engagement opportunities with healthcare services, especially when they're related to alcohol or other drug use. So during these service presentations, it's an opportunity to re-engage clients in alcohol or other drug support. Also, these health information systems, if we can improve communication between AOD services and health services. We know Australia has the infrastructure to do this, but obviously there are privacy concerns around this. And finally, improving treatment record keeping. I had to deal with a lot of dubious data and missing data, but understanding that often these environments are resource poor in terms of time. So finding strategies such as routine outcome monitoring with feedback that can help navigate this challenge, and also getting community input to ensure that the measures that we're collecting and the outcomes we're looking at are relevant to those who actually utilize the services, and see if they have any input on reducing this burden. I also just wanted to mention, as Sarah touched upon, it is Close the Gap Day today. We did not aim to investigate in further depth beyond a demographic characteristic, Indigenous Australian people being and or identifying as Indigenous Australian. This requires much more sensitivity and culturally appropriate understanding, as it's very complex. Also highlighting the females who seek treatment that I touched upon for the mortality. I believe these are definitely priority populations that require more attention. Just before I wrap up, I'm not ignoring all of the limitations that are in data linkage, and don't worry, I'm not going to read this all out. I just wanted to highlight that there are a lot of limitations with this methodology. And in particular, the delayed nature of data linkage. Not only is it retrospective, but also the process of linking the data that was further delayed by COVID for my project. So there could have been a lot of changes to these programs in the 7 to 10 years that happened since it was collected. That being said, the reason I put all those limitations on the screen are just to highlight that without data linkage, this is the picture that we might have, just the baseline episode. And so at least by linking this health service data, while there are limitations, at least we can start to get some and obtain some reliable outcome measures that are clinically relevant, and start to get a picture of what happens to someone following their discharge. Just before I wrap up, I just wanted to highlight that this thesis is novel research. So it is very new, and it represents a starting point for potential methodology of investigating this population. And despite that, it still shows the capabilities of this methodology in this setting. The evaluation of the service in terms of what types of long-term outcomes happen from planned, structured, and relatively risk-free time away from substance use. And data practices have improved a lot since 2014 and 16 from when this was collected. Finally, just before I finish, I want to contextualize these findings with practice. So all of this PhD work was presented to the service provider during their clinical governance meeting. And it was really interesting to see how aligned these findings were with the practices and initiatives that had been implemented since this data was collected. So I wasn't even aware of these at the time. I was of routine outcome monitoring, but suicide prevention and procedures for preventing suicide, such as screening and greater support around it, as well as expansion of continuing care services. And I think this really just highlights that there's so much opportunity to use data linkage to continue evaluating and improving services, and also improving the outcomes of those who access those services. So I'll end there. I'm sure that was a lot of information, and I may have gone a bit over, but I look forward to any questions you might have. Thank you.
Thanks so much, Calvert. Wow, what a big PhD. Congratulations. It's a really impressive piece of work. I've made a ton of notes here about how you've managed the data, and even just getting together the data sets and then creating the cohorts is like quite the task. So well done. I'll take this opportunity now to invite Dom to please turn on her camera as well. If we can get the tech all lined up. Beautiful. Isn't that great when that works? And congratulations, Dom. I understand that you're one of Calvert's PhD supervisors, so I'm sure you're pleased to see this all come together so nicely as well.
Yeah, Calvert's done such a great job. It's such an impressive amount of work, and using linked data and mastering different types of analyses, sophisticated types of analyses to best utilize linked data is quite difficult. So I really commend him on that. I guess I wanted to start by just saying that what Calvert's done here is quite unique, in that 5 or 6 years ago, you could count on one hand how many published studies there were internationally that had used linked administrative data to look at outcomes of people that had come out of AOD residential treatment. And one of the biggest limitations in this work, in using traditional methods of data collection, is not accounting for deaths. And obviously, individuals that are coming out of AOD residential treatment are at high risk of death and have very complex needs. So Calvert's work's filling a great knowledge gap that's been there on better understanding that risk and what proportion of individuals might be at risk of death, and essentially the bias that we might be seeing in using traditional methods of data collection. I wanted to ask Calvert if he got a sense from the data about what kinds of complex needs individuals exiting treatment might have and how this might inform wraparound care.
I think it's a really broad question. This population has, I think they experience a lot of poorer outcomes in general, and as I touched upon, they also have long histories, typically that don't start when they enter treatment. But we know that there's high comorbidities with mental health. We know that there can be a lot of new work coming around trauma, suicidality, as I touched upon as well. And I guess in terms of wraparound care, just keeping individuals who access these services engaged is extremely hard given all of these situations, and this extends to financial as well. Despite being a subsidized service, that would still add a factor. I don't know if there's a specific answer to that question. I think that's what people have been trying to answer, is how do we create wraparound care, especially given that it typically is a resource poor treatment options that we can provide. So it's not only about what care can we provide, but also how can we provide it and where is it coming from? I don't know if that answered your question, Dom.
No, that's great. I was thinking a little bit about justice involvement, and that's another type of source of data that you can link in to these types of studies to account for people that come in and out of prison in those times that they may appear to not be accessing services or turning up to services when in fact they're in prison. And I wonder if you have an idea of what proportion of people in this group were justice involved at the time that they came in.
Yeah, so I did touch upon this. So at admission, we did get an idea of how many people were, for example, court mandated or had any kind of interaction with the justice system, whether that be they're on bail, for example, or remand. And I think it was around 37%. I can't remember specifically. But this being said, while we didn't capture that corrective or police data even, and that could account for periods when individuals shouldn't have been followed up because they potentially couldn't have accessed substances, we also know that people can access substances while in corrective services. And we also had emergency department data, which people from prisons access EDs in that database as well. So we could, to some level, see if individuals had potentially gone into prison and if they needed ED support during that time. But beyond that, it definitely is a limitation that we weren't able to address, especially given there would be a high proportion who potentially did go into corrective services during this time.
Yeah, great answer and interesting question. One of the things I was wondering, Calvert, when you were talking, was if you had like a magic data linkage wand and you could get another piece of data or another variable or another data set that you could link with the information that you've got, what would it be?
Do I only get to pick one? Because I think
all right, we can have two.
Yeah, I think this is actually a good question because I've thought about it a lot, and a lot of things come to mind. So definitely the historical factors. One of the things that we didn't have is what were people doing before their episode of treatment. As I was saying, that this isn't isolated. Typically, people who use substances have been doing so chronically for years. So we didn't have any of that information. We don't know if they were always using the primary substance that they presented for. We didn't even have that much information on primary substances. So how much were they doing, the frequency, the severity? And we didn't really understand their usage. Trauma was another thing that I would have loved to have. All of the linked data that Dom was just talking about. And the list could go on. Even touching upon stress factors and mental health in general. One thing that I probably would also add is primary care is something that is pretty separate from all of the linked data that we collected. I guess it's within the same system, whereas primary care maybe isn't in the same system as these services. So there's not as much transitioning between, for example, hospital and ED that you could track with these data sets. Whereas if someone's come from primary care, we wouldn't know, and they could have stopped at primary care with AOG
Sure.
supporting them.
Yeah, that's a great question. You've introduced the next question that I'm going to ask you beautifully. Thank you. Matt Stevens has asked about, he said, thanks for the fascinating talk. I was wondering if you have any information on comorbidity, for example, schizophrenia or previous hospital admissions for episodes of depression.
Yeah, I think this actually is very related to what I just brought up, in that we don't actually have that information.
Yeah.
Unfortunately, these episodes, for example, in hospital, they're only related to the episode in hospital. They don't provide a history of what happened before. And also remembering that this data is collected with not with it, it's completely de-identified. So it's very sensitive in that you only get the data that you ask for. And I'm sure Dom can add to this. So if you want the data that happened before 2014, then you'll have to also seek that out. You can't just access it because there are so many questions that you could answer if you did have it.
Yeah, that's great. That leads nicely to the next question we've had from Anthony, who is saying fascinating research. What are some of the technical challenges? Perhaps you could talk around some of the technical challenges of obtaining and analysing and creating cohorts using linked data sets like you've done. I'm sure this could go on for a while.
Tom, did you want to approach this question? I feel like I've talked a lot.
I think with Calvert's study, the cohort came from the treatment service, so we knew that we were capturing everybody. But in a lot of other data linkage studies, you develop a cohort from administrative data. So, for example, if you want to capture all young people in a state, you're going to miss, you need to find a point in time that those individuals were measured in some administrative data set. And you'll start to miss, once you start following them, they may move in and out of states. So for example, with Calvert's study, some of these people may have moved into state and they're no longer accessing services, and they may be experiencing some really poor outcomes, but they're not in the state where the data came from. So that's probably one of the challenges in that you will lose some people. There's also the linkage isn't it's not always perfect, so you do lose a small proportion of people in the actual linkage process, or the linkage may be slightly incorrect, and there's about 1% to 2% of cases generally that linkages that you can't utilize. But yeah, I guess also there's a lot of cases, especially when you're talking about suicide, where individuals are going to experience suicidal ideation and engage in suicidal behavior, and they won't access an acute health service. So we don't have that information captured. Yeah, that's probably the main things that I can think of.
Yeah. I mean, it's a good point. It's always important to remember, I think, with this, when we're looking at linked data and administrative data, it's captured for a different purpose. The research is sort of secondary, and so we do what we can, but it's not primarily developed with that in mind. So yeah, great answer. Thanks, Dom. Natalie has just asked on the chat, she said, congratulations for your research and thanks for presenting. She's asking, do you know whether the 30-day higher risk period relates specifically to the residential rehab, or does it also relate to other drug and alcohol services, such as counselling or other services that people might access? Do you have an understanding of that?
I don't know if I could speak to counselling specifically. Maybe Dom could jump in after, but I do know that this critical period appears in other populations. So I think that's where we kind of started to look for this critical period of increased risk. We know what happens with substance using populations following treatment. When I was looking, it also occurs in other conditions following hospitalizations. So I wouldn't be surprised if it did occur with counselling, but I wouldn't know specifically and couldn't speak to it. Sarah, you might know. Dom, you might know.
That critical period is exactly the same, the research shows, for people that are coming out of prison. And I think it's probably, I don't 100% know, but I suspect that it's quite unique to a residential treatment setting. Similarly with prison, in that they're in an environment, a care environment, where essentially they've gone through withdrawal, they don't have the same access to drugs and alcohol, and I think it's a different setting to getting treatment in the community, and that it would impact that critical period, because part of the critical period, part of the issue is that the risk of overdose is because they have gone through withdrawal and don't have access to drugs and alcohol, that they are at risk of higher risk of overdose when they come out of those settings.
Yeah, so it's a bit to do with the change of context and environment as much as anything. Yeah, well answered. Thanks. You've got me thinking a bit about like how these types of data could be used, and it strikes me, I mean, you gave a really nice example of high levels of stress, and I think it was severe stress amongst people who had poorer outcomes. I'm wondering if you have any thoughts on whether it is happening or whether it could happen, that data like this is used as a way of, you know, predicting or tailoring care for people, you know, at the beginning of their time in a service, and saying, okay, perhaps these people have particular vulnerabilities or particular things that we need to look out for, as a way of sort of tailoring treatment at that point. It's a bit of a curly question, I'm not sure, but did you have any thoughts on that?
Yeah, I think obviously if you could create a profile of a client as they enter treatment, and you could see potentially what factors might influence their outcomes, that could definitely mean that you could tailor their treatment. So if someone's coming in with more like a dual diagnosis, then you could tailor the treatment towards that. For example, trauma-informed care. If you know that someone's coming in or has a history with trauma that you can identify through health services, then perhaps you could meet that person with their needs a lot sooner. That being said, one of the biggest limitations with data linkage is the delay that it takes to receive this data. And I touched upon the fact that the health information systems don't communicate. When people go to services, for example, like an ED presentation for overdose, the AOD service wouldn't know about that, when in reality, it might actually be the service that should know about it, so that they can re-engage someone during this episode. Instead, they're probably just sent home. So I guess my point is that there's really missed opportunities, not only to tailor treatment for people so that it's more effective or gives them what they need, or what the person using the service thinks they need, but also that there's missed opportunities to, on the other side, so following treatment and re-engaging people, because it's like these key opportunities where people actually might need treatment or want treatment or ready for treatment, which we know improves outcomes. Dom, I don't know if you want to add anything onto that.
I just wanted to say that there's a lot of work happening in other spaces, such as suicide research with linked data, where it's really like blatantly clear that without services talking to each other, people are at particularly high risk of poor outcomes. And I think maybe not in the AOD space, but we'll see some traction happen in data sharing in these other spaces that will eventually flow on to this area, I think.
Yeah, that's a really That's a great point. It just always takes time to change these systems and for things to happen. But that's a great spot to finish on, I think. I was thinking, Calvert, about what you were saying about presenting it back to the service providers and then already having quite a clear sense of what was happening in the data, and they'd already created some of those processes and procedures around responding. So I think that's a really nice way of thinking about it, is they've sort of got that insight already, but this just is another piece of the puzzle. Did you want to finish with any points just before we wrap up, Calvert?
Just going off of what you were just saying, I think it was a really good opportunity, as often it's hard to get a line of communication towards between practice and research. So it was a great opportunity. And I think also it goes both ways. You know, they were saying that they really wanted to know this kind of information, like what does happen to people? Do our treatment services actually work? So I think it was a unique opportunity, and I hope it was helpful. But it'd be good if there was more opportunities like this, where there is more of an open dialogue between services and evaluation teams. But yeah, that's probably all I have to say about it.
That's great, thanks. And Dom, did you want to, I just wanted to invite you to add any concluding thoughts or remarks before we wrap up?
No, not particularly. I just again commend Calvert. Such a huge amount of work, and I'm sure it is having an impact with services and better understanding even critical periods, because that's been a big debate over a long time. So yeah, really important work.
Yeah, that's great. Excellent. All right. Well, I'd really like to thank both our speaker and our panelists today, to Calvert and to Dom. Thank you for taking the time to talk to us and share your thoughts. We're going to close today's webinar in just a moment. I'd just like to flag our upcoming webinars. Next week, we're having a holiday for Easter. I'm sure no one will be at work at 4 o'clock on Thursday afternoon next week. So we're going to take the week off. And the following week, we'll be back for an exciting webinar looking at how the Who Assist has been used in post-release research after prison. So have a great Easter, everyone, and we'll see you after the break. Thank you.